Let me tell you about a case. Middle-aged guy came to the ED with the worst abdominal pain of his life, epigastric pain radiating to the back. He had been at the wedding the night before, big food, a lot of biryani, a lot of meat. Junior doctor sends him for ultrasound, and the ultrasound comes back as normal. No gallstones, no free fluid, and the pancreas was not visualized because of the extensive gut gases. And someone writes normal ultrasound, reassured the patient in the notes, and sent him home. He deteriorates. 36 hours later, he is in ICU. ARDS, renal failure, third spacing everywhere. And when they finally do the CT, it looked like a bomb had gone off in his abdomen. That's the lesson for today. Pancreatitis is the diagnosis of clinical suspicion confirmed by labs, but radiology is how you grade the war. When you don't know what to look for, you will miss the fire while it's burning. Today we are going deep into acute pancreatitis, not just the facts, but the whole story, why it happens, what it looks like, how we grade it, what complications we hunt for, and most importantly, what the scan is actually telling the surgeon about this patient's future. This is Beyond the Scan. I am Dr. Saqib Hamza, and let's go. Okay, before we touch the imaging, we need to understand what is actually happening inside the gland, because if you understand the pathophysiology, every imaging finding becomes obvious. The pancreas makes digestive enzyme, we all know that. Powerful ones, lipases, amylases, and proteases, and it stores them as inactive precursors, zymogens. Exactly, because they are so dangerous. They are only supposed to activate in the duodenum once they are out of the gland. Pancreatitis happens when those zymogens activate inside the pancreas. Suddenly you have paralytic enzyme whose only job is to break down the protein, being released in an organ which is made up of protein, and the pancreas starts digesting the organ itself. Trypsogen gets converted into trypsin. This is the master trigger. Once trypsin is activated intrapancreatically, it cascades, activating phospholipases, elastases, and more. It's not just inflammation in the traditional sense, it's autodigestion. And it does not stop there. The enzymes don't stay neatly inside the pancreatic capsule. They leak into the peripancreatic fat, they track along the fascial planes, they get into the retroperitoneum. Phospholipase attacks the cell membrane, elastase destroys vessel wall, hello hemorrhage, and then lipase digests the fat, hello fat necrosis. And that's when it gets bad enough. The inflammatory cascade goes systemic, surge, cytokine storm, and suddenly this is not just an abdominal problem, it's a whole body emergency. And that's why pancreatitis kills, not because of the pancreas itself, but because of what it triggers everywhere else. Before we go any further, I need to tell you something that most textbooks bury in the footnote. Acute pancreatitis is not one disease, it's a spectrum. And the 2012 revised Atlanta classification finally gave us the language to describe it properly. At the top level, there are fundamentally two different types, and understanding which one your patient has changes absolutely everything about the management plan. Number one is the interstitial edematous pancreatitis. This is the common one. About 80% of the cases, the pancreas is inflamed, it's edematous, it's angry, but critically the parenchyma is still alive. On CT there is diffuse or focal enlargement, peripancreatic stranding, maybe a small fluid collection. And here is the key, the whole pancreas enhances uniformly brightly. There is living tissue inflamed but still alive. Most IOP resolves within a week with supportive care. We give fluid, analgesic, monitoring. Mortality in uncomplicated IOP is less than 3%. These patients make you feel good as a doctor. Type 2 is the necrotizing pancreatitis. This is the 20% that keeps you up at night. Here the autodigestion has gone further. Tissue is actually dying here, and that tissue, necrosis, is a completely different clinical beast. Now necrotizing pancreatitis has three different subtypes. Stay with me because this actually matters. The subtype 1 is the pancreatic parenchyma necrosis only. The gland itself is dying. Peripancreatic fat is relatively spared. On CT, there is non-enhancing areas within pancreatic parenchyma. The gland has dark holes in it. The subtype 2 is the peripancreatic necrosis only. This one surprises people. The pancreas itself enhances normally. It looks normal, but the fat around it is necrotic. The collection around the pancreas contains solid necrotic material. On CT, normal looking pancreatic enhancement but heterogeneous peripancreatic collection. This subtype is more common than most people think, and it's quite easy to miss this one because you are looking at the pancreas and the pancreas looks normal. Subtype 3 is the combined one, pancreatic and the peripancreatic necrosis. This is the worst one because both the gland and the surrounding tissue are dying simultaneously. This is your CTSI of 8 to 10. This is an ICU patient. So now you might be wondering why this classification matters so much. Because IOP collection, APFCs, mostly resolve. You watch them. Necrotizing pancreatitis collection, ANCS1, contain dead tissue. Dead tissue can't be drained with a needle alone. It's need necrosectomy. This classification is literally telling the surgeon what operation they are walking into. Get the right type, use the right words, and it's not just academic, it's clinical. Okay, now the causes. What triggers the autodigestion? There are two giants worldwide, gallstones and alcohol. They account for roughly 80% of the cases. Gallstones cause pancreatitis by obstructing the common channel at the tempura of beta. Bile reflexes back into the pancreatic duct, pressure builds, and the acinar cells gets injured. The zymogens activate, and the war begins. Alcohol does something different. It's toxic directly to the acinar cells. It also causes protein plugs in the small ducts, microobstruction. The exact mechanism is still debated, but the clinical outcome is same, autodigestion. Now, if you are working in the LMICs or countries like Pakistan, you need to think about this list a bit differently. You have to look for the hypertriglyceridemia, far more common in our diabetic, metabolically unwell population. Triglyceride of more than 1000, this is a cause. Then choledocholitis, primary duct stones common due to the dietary pattern and the delayed healthcare seeking that we have. Then Ascaris lumberites, yes, a roundworm in the biliary system. It happens. ERCP stories your senior will tell you. Post-ERCP pancreatitis, as we do more ERCPs in our tertiary centers, this is becoming increasingly relevant. Then trauma, especially penetrating abdominal trauma in our setting. And lastly, drugs, azathioprine, steroids which we take a mouthful every day. This is something to look for. There are other causes as well, like hypercalcemia, autoimmune pancreatitis, or genetic causes like PRSS1 mutation, for example. These matter too. But statistically, in our setting, always go for gallstones first, always. And that means the ultrasound matters, not for the pancreatitis itself, but to rule in or out the gallstones as in etiology. So when do we actually scan? Here is something that surprises junior doctors. And this surprised me too. In uncomplicated acute pancreatitis, you often don't need a CT. The diagnosis is clinical plus labs. Epigastric pain plus serum amylase or lipase more than the 3x times the normal limit. Or you have the characteristic CT finding, 2 of the 3 things, and you are done. An early CT, especially in the first 24 to 48 hours, can actually underestimate severity. The full extent of necrosis does not become visible until 48 to 72 hours in. So when do we actually scan? The ACR and IAP indication for CT in pancreatitis. Firstly, if you have diagnostic uncertainty, the pain is atypical, the labs are ambiguous, you need to exclude other causes like mesenteric ischemia or hollow viscous perforation. Secondly, clinically severe presentation, SIRS, organ dysfunction, Ranson score of more than 3 or FHS2 score of more than or equal to 8. Number 3, failure to improve after 48 to 72 hours of conservative treatment. Number 4, clinical deterioration, new fever spikes, worsening pain, rising inflammatory markers, and lastly, suspected complication. If you suspect abscess, pseudocyst, vascular complication, or the hemorrhage. And when you do the scan, you want contrast. Intravenous contrast is what allows you to see the perfusion. Without contrast, you can see the inflammation. With contrast, you can see what's alive and what's dead. Necrosis is dead parenchyma that does not enhance. You cannot call necrosis without contrast. The exception, it is only renal failure. Then you are making a clinical judgment call. Okay, you have got the CT, the patient is on the table, report is open in front of you. What are you looking for? Think of it in layers. Start at the pancreas itself, then move to the peripancreatic fat, then the facial planes, then the rest of the abdomen, and lastly look for the complications. In pancreas, look at the size. Is it swollen? A normal pancreas tapers smoothly from head to tail. In pancreatitis, even mild one, it looks edematous, bulky, the outline is less crisp. Secondly, look at the density. A non-contrast CT, normal pancreatic parenchyma is homogeneous. In pancreatitis, edema makes it slightly less hypodense relative to normal. Third, and this is the crucial one, enhancement on contrast CT. Normal pancreas enhances brightly and homogeneously on the portal venous phase. And this is your primary assessment phase in most real-world pancreatitis scans, when an arterial phase may not be available. Areas of necrosis do not enhance. They remain dark, hypodense, while the living pancreas around them lights up. That's pancreatic necrosis, and the extent of that non-enhancement changes everything. The enhancement pattern is very simple. If there is homogeneous enhancement, normal density, this is mild edematous pancreatitis. Likely very good outcome. If there is heterogeneous enhancement, evolving necrosis, we watch carefully. Non-enhancing area. This is pancreatic necrosis. We quantify it. Is it less than 30%? Is it between 30 to 50%? Or is it more than 50%? More than 30% necrosis, this is severe ICU patient. We get the surgical input. The CT has just changed everything about the patient treatment plan. Then look at the peripancreatic fat and fluid, stranding that smudgy gray haziness in the fat around the pancreas. It's edema, it's enzymatic inflammation, eating into the peripancreatic fat. In mild diseases, a little stranding, this is quite normal. In severe diseases, it extends everywhere along the facial planes, down into the pelvis. And then you look at the fluid collection. Free fluid in the lesser sac, in the left interior perirenal space. This is the peripancreatic fluid, acute peripancreatic fluid collection, or APFCs. These are early non-encapsulated ones. Most will resorb and some becomes the pseudocyst. Then you look at the facial planes, enzymes track. That's their nature. They follow the path of the least resistance. The pancreas sits in the retroperitoneum. Enzyme escapes the retroperitoneum and track down the interior perirenal space along the transverse mesocolon. The colon can get inflamed and sometimes necrotic into the mesentery, and this can cause a mesenteric fat necrosis. It can also go behind the descending colon all the way up to the pelvis, and rarely up into the mediastinum via the aortic or the esophageal hiatus. The pleural effusion, mediastinal inflammation. Left-sided pleural effusion in pancreatitis means enzymes are tracking via the aortic hiatus. It's a marker of the disease severity. It means the fire has spread beyond the abdomen, and it explains why your patient has hypoxia, not just from the ARDS, but from the effusion compressing the left base. Now this is where we move from describing what we see to telling the clinician something useful. Severity scoring. This is your job as a radiologist. Not just there is peripancreatic straining, but what does this mean for this specific patient? The gold standard scoring system is the CT Severity Index, the CTSI, developed by the Balthazar. It combines two components, the Balthazar grade and the degree of pancreatic necrosis. The Balthazar grade A is normal, nothing is happening there. The grade B, the gland itself is swollen. Fire is inside the organ. The grade C, fire has jumped into the peripancreatic fat and you get the straining. In D, fire has created one collection, fluid is pooling, and E, fire is out of control, multiple collection or gas. And for each grade you give points according to that table. Then the necrosis. If there is no necrosis, this is 0 point. If necrosis is less than 30%, this is 2 points. If necrosis is between 30 to 50%, we give 4 points. And if necrosis is more than 50%, we give 6 points. So the CTSI gives the Balthazar grade points plus necrosis point. These are maximum 10 points. The CTSI between 0 to 3, this is mild disease. Morbidity is less than 3% and mortality is nearly 0 if you properly treat the patient. The CTSI between 4 to 6, this is the moderate disease. Morbidity rises to 35% and mortality to 6%. The CTSI of 7 to 10, this is the severe disease. Morbidity up to 92% and mortality up to 17%. Then there is modified CTSI, which also scored the peripancreatic complication and the extrapancreatic complications. Both are valid. No, both exist, and report whichever your institution uses or the local guidelines use. The principle is same. Quantify the damage so the surgeon knows what they are walking into. So here is our patient, 32 years old, epigastric pain, MLAs of 1800. Let's look at the CT. The first thing I always do, I go straight to the pancreas on the portal venous phase. Is it swollen? Yes, look at that. The whole gland is plump. Normally you would see a nice tampering from head to the tail. Now the critical question, does it enhance? Look at the portal venous phase. Yes, the gland is lighting up. Bright, uniform, homogeneous enhancement throughout. That's living pancreatic tissue. And this is the key point. On portal venous phase scan, a normally enhancing pancreas means no necrosis. You don't need an arterial phase to make that call in most cases. The portal venous phase gives you the perfusion information you need. Now look at the fat around it. See that haziness, that straining? That's the inflammatory reaction spreading into the peripancreatic fat. It's confined though. It's not tracking anywhere crazy. You also get a little bit of fluid here in the lesser sac. That's APFC. No wall, no debris, just clean fluid. CTSI, Balthazar C, 2 points. There are no necrosis, so 0 point. Total 2 points. And this is mild pancreatitis. This patient is going to be fine. Fluid, analgesics, monitor. But look at this case and lock in what the normal enhancements looks like. Because next we are going to show you what happens when it's not there. Now different scenario. This patient had severe episode of pancreatitis weeks ago. This is the follow-up CT. Something still is not right. Look at this collection. It's massive, sitting right where the pancreas should be. First thing, does it have a wall? Yes. Thick defined encapsulating wall. That tells us we are beyond 4 weeks. This has matured. Now the critical question, what's inside? It's heterogeneous. There is solid material. There is debris. There is some fluid. And there are multiple air foci. This is not a pseudocyst. A pseudocyst would look like water in a bag. This is walled off necrosis 1. The word necrosis matters here. It means solid debris inside, and that debris can't be drained with a simple needle. You need endoscopic necrostectomy or surgical debridement. Different patient, a different story. Look at the CT compared to the case 1. Same organ, completely different disease. This is the portal venous phase. You can see that the pancreas is swollen. You can also see peripancreatic fluid and fat straining, particularly around the pancreatic tail. You can see many areas of hypotension, especially in the tail and in the body region. That's not an artifact, that's the dead pancreas. And that is why the portal venous phase is your workhouse in pancreatitis. Necrosis shows up as areas of hypotension that fail to enhance, clearly darker than the surrounding viable parenchyma. Complications, the monster we hunt. This is where radiology really earns its keep. Pancreatitis has a list of complications that are individually dangerous and collectively lethal. Your job is to find them, report them clearly, and use the right terminology. Number 1 is acute peripancreatic fluid collection or pseudocyst. Early pancreatitis often produces fluid around the pancreas, in the lesser sac, in the perirenal spaces. This is APFC. It's peripancreatic. It has no defined walls. It's homogeneously fluid density. There are no solid components confined by the normal retroperitoneal facial planes. Most APFCs resolve spontaneously within 4 weeks, so we don't over-report them. And if they persist beyond 4 weeks and develop a well-defined wall, they become the pseudocyst. Now I need to teach you the revised Atlanta definition of pseudocyst carefully, because this is where a lot of people get confused and where textbooks have historically been sloppy. By the 2012 revised Atlanta classification, a pseudocyst arises from the interstitial or edematous pancreatitis, not from the necrotizing pancreatitis. That's the key origin point. It contains fluid without solid necrotic pancreatic tissue, encapsulated, walled, and mature. But, and this is important, a pseudocyst is not always a perfectly anechoic, eco-free, pristine fluid bag on every modality. In real imaging, early pseudocyst can contain internal echoes and debris from hemorrhage or early evolution. Infected pseudocyst can impair complex with internal echogenicity. On MRI, internal dependent debris is actually a high specific finding for pseudocyst. This helps distinguish it from the cystic neoplasms. So the separator between the pseudocyst and one is not any debris, it's solid necrotic pancreatic tissue. That's what one has, dead parenchyma, solid chunks of necrosis. A pseudocyst with old blood or inflammatory debris is still a pseudocyst. A collection with solid dead pancreatic tissue in it is a one. This ends here. One more thing, and your seniors may not tell you this. True pseudocysts following acute pancreatitis by revised Atlanta criteria are actually uncommon. Most mature collection you will see post-acute necrotizing pancreatitis that were historically called pseudocysts. They are actually one, misclassified under the old terminology. The old Atlanta 1992 called everything a pseudocyst. The 2012 revision fixed that, use the 2012 terms. Now why does this even matter? Because the intervention threshold is completely different. Pseudocyst, we drain it with a simple needle or endoscopic transmural drainage if symptomatic. If it is one, then the solid necrotic debris cannot be drained with a needle. It needs necrosectomy. Wrong terminology, wrong planned procedure, and the patient on the table for the wrong operation. Number 2, acute necrotic collection or the wall of necrosis. Now this is the serious stuff, the necrotizing pancreatitis collection. In necrotizing pancreatitis, dead parenchyma liquefies. This creates acute necrotic collections, ANC, heterogeneous content, mixed fluid and solid necrotic debris in the pancreatic bed. No encapsulating wall, this is acute and this is dangerous. After 4 weeks, if the ANC develops a mature wall, it becomes a wall of necrosis. 1. Heterogeneous solid plus fluid content plus a thick defined enhancing wall. The heterogeneity, the solid necrotic material, is the defining feature. That's what separates it from the pseudocyst, not just the echo, solid dead pancreatic tissue. The CT sees it as non-fluid density heterogeneous content. MRI sees it as T2 high point and solid material within the collection, very clear on T2 weighted sequence. And this is where MRI and it keeps. CT can underestimate solid content. A collection that looks homogeneous on CT can show clear solid debris on T2 MRI. That changes the diagnosis from pseudocyst to one. That changes the operation entirely. Number 3, infected necrosis and abscess. One of the most feared complications. Mortality jumps significantly once necrosis get infected. The CT sign, gas within the collection or within necrotic parenchyma. Gas in the pancreatic bed that is not from the adjacent bowel loop. Presume infected necrosis until proven otherwise. But here is the trap. Infected necrosis often has no gas. So the clinical suspicion drives it. Fever spikes, rising CRP, deterioration at 1 or 2 weeks. FNA under the CT guidance to confirm. But that's the interventional team jobs, not yours to initiate. Number 4, the vascular complications. These are the hidden killers. Elastase does not care about the vessel wall. It digests it. Result, pseudoaneurysm, hemorrhage, venous thrombosis. The pseudoaneurysm most commonly in the splenic artery, also the gastroduodenal hepatic artery. On CT, you get a sac-like structure adjacent to the pancreas with arterial enhancement. Same density as aorta in the arterial phase. This is the radiology emergency. Pseudoaneurysm rupture kill. In hemorrhagic pancreatitis, you get high density fluid or collection on the non-contrast CT. Blood is pooling in the retroperitoneum. The Cullen sign, the Gray Turner sign, these are clinical signs of retroperitoneal hemorrhage. Then there are venous thrombosis. Splenic vein is the most commonly affected one. Also the portal vein and superior mesenteric vein. The consequence is the sinistral portal hypertension. You get gastric varices, which can bleed years later. So look for it on the venous phase, absent opacification of the splenic vein. You can also get the bowel complications. The transverse colon is the most vulnerable one. It runs right across the pancreatic body. Enzyme track along the transverse mesocolon, cause colonic well edema, inflammation, ischemia. Colonic necrosis is rare but catastrophic surgical emergency. This is the one that I want you to truly fear respectfully, clinically. Patient with non-necrotizing pancreatitis brought back up for the scheduled follow-up CT, feeling okay. Actually, I am doing my usual sweep, pancreas collections, biliary. Wait, stop right here. Exactly. Wait, stop right here, exactly at tail. See that round structure? Let me put a measurement on it. It is around 3.2 centimeter. What is the density? It is going to be high. It is going to be high. Look at it on the arterial phase. This is the arterial blood, still brightly opacified. On the portal venous phase, a pseudoaneurysm will still enhance strongly because arterial blood persists throughout the contrast window, and that's how we catch it. If you look at the arterial phase, you can clearly see it. This is pseudoaneurysm of the splenic artery. Elastase from the necrosis has digested the vessel wall. It's being held together by clot and fibrin. It will rupture. It's a matter of when. If you see something like this, you pick up your phone and call the interventional radiologist team. You need the embolization at that moment because this could save the patient life. Gastric outlet obstruction from a large pseudocyst or wound compressing the stomach or duodenum, or you can get the biliary obstruction from edema or pseudocyst at the pancreatic head compressing the CBD. All of these are visible on CT if you are looking for them. Throughout this video, we have been CT focused, and rightly so. CT is the workhouse of pancreatic imaging, but CT is not the whole story. Let me place the other modalities properly. Ultrasound. Ultrasound is the first line, not for the pancreatitis itself, but for etiology. You are asking, why did this patient get pancreatitis? Gallstones in the gallbladder, CBD dilatations suggesting a past or impacted stone, hepatomegaly or fatty liver suggesting alcohol or metabolic cause. And I want you to say this in every report where the pancreas is not seen. Pancreas not visualized due to overlying bowel gases. CT recommended if clinically indicated. Failure to see the pancreas on ultrasound is not a reassurance. It's a limitation of the modality. Gas sits in the transverse colon right over the body of the pancreas. It hides everything. Don't let the limitation get away as normal. Then there is MRCP, which is your gold standard for biliary system, non-invasive, no radiation, no contrast, and no nephrotoxicity. Primary use if there is CBD stone that ultrasound has missed. If the duct is dilated and you cannot see a stone, you order MRCP. But MRCP does more than find stone in pancreatitis specifically. For example, the ductal disruption. In severe necrotizing pancreatitis, the main pancreatic duct can rupture. This creates a disconnected duct syndrome. The tail drains nowhere, keeps leaking enzyme. MRCP shows the break in rectal continuity. This is clinically very important. In post-pancreatitis stricture, patient who survive severe pancreatitis can develop ductal strictures, chronic pain, exocrine insufficiency. MRCP makes the anatomy beautifully. And now the one that people forget, MRI. MRI does not get talked about enough in pancreatitis because CT is so dominant. But there are 3 situations where MRI is genuinely the better answer. And you need to know all 3 of them. Number 1, if you want to assess necrosis, but the patient is in renal failure and the creatinine is very high. In this situation, gadolinium enhanced MRI is your answer. Number 2, autoimmune pancreatitis. Now this is genuinely important, and it's a pitfall that has caused patient their pancreas. Autoimmune pancreatitis type 1 is an IgG-related systemic disease. It causes pancreatic inflammation that in CT can look terrifying like pancreatic cancer. Focal mass at head, upstream duct dilatation, obstructive jaundice. The surgical team sees this CT and start booking for the Whipple procedure. But AIP has features and MRI shows them much better than CT. The sausage pancreas, diffuse enlargement of the whole gland, smooth contour, loss of lobulation, the capsule-like rim, a peripheral halo of low T2 signal surrounding the gland, fibroinflammatory tissue. In AIP, the pancreatic duct is narrow throughout, not obstructed at one point. In pancreatic cancer, you get a focal obstruction with upstream dilatation, the double duct sign. In AIP, the duct is diffusely irregular and narrow, completely different pattern. And the enhancement, AIP shows delayed enhancement on gadolinium, slow progressive filling. The pancreatic duct adenocarcinoma is hypovascular. It stays dark. AIP eventually enhances, characterizing the cystic lesion in the post-pancreatic pancreas. For example, the patient had pancreatitis 6 months ago. Follow-up CT shows a cystic lesion in the pancreatic tail. Is it pseudocyst? A serious cystoadenoma? The CT struggles with this, but MRI finds the answer very well. Okay, let's land this. 5 things I want you to take away from this, and I mean actually remember from today. 1. Pancreatitis is autodigestion. Zymogens activate inside the gland. Understanding the biology makes every imaging finding make sense. Don't memorize the findings, understand them. 2. There are 2 types. Interstitial edematous, the pancreas is alive, inflamed, recoverable. Necrotizing parenchyma or peripancreatic fat is dying, and that changes everything. The classification dictates the collection type, the management and the operation. Get it right, use the revised Atlanta terminology every single time. Number 3, score every pancreatitis CT with CTSI, not Balthazar grade alone. The full index, necrosis percentage plus the grade. State it in your impression. The surgeon reads your report and needs to know the number, not just the words. 4, MRI is not just for the biliary tree. It assesses necrosis when CT contrast is contraindicated. It catches autoimmune pancreatitis before someone removes a healthy pancreas, and it characterizes post-pancreatitis cyst that CT cannot tell apart. Know when to reach for MRI, it earns its keep. 5, hunt for the vascular complication on every pancreatic CT, pseudoaneurysm, splenic vein thrombosis, hemorrhage. These are the quiet killers. If you don't look them, you don't find, and if you don't find, someone dies. Pancreatitis is not a boring diagnosis. It's a complex battlefield, and the CT scan is your map of that battlefield. Learn to read it properly, and you will change the outcomes. This is Beyond the Scan, and I will see you in the next one.